Next session, I invite the chairpersons, Dr. Rajpal Singh, Consultant Electrophysiologist at Apollo Hospital, Bangalore, Dr. Ramesh Pai, Dean and Professor at KMC Bangalore, and Dr. Kishore Kumar, Professor and Head of Department at Yenapoya Medical College. I invite Dr. Bobby John onto the dais to speak on QT interval, how should it be measured, what does it imply for a physician. I request the chairpersons to introduce Dr. Bobby John.
Good evening. To discuss on the most loud and at the same time dreaded interval, we have Mr. Dr. Bobby John, who is Professor of Cardiology and Acting Head of Cardiac Electrophysiology at Christian Medical College, Vellore. He has been awarded Doctor of Philosophy in Medicine from University of Adelaide, Australia, with special interest in rheumatic atrial fibrillation. Has a fellowship of Heart Rhythm Society, USA, a membership of National Academy of Science in New Delhi, and fellowship of Royal College of Physicians, Glasgow, FRCP, fellowship of American College of Cardiology, USA. Over to Dr. Bobby John.
Respected Chairman and dear friends, ladies and gentlemen, it is always difficult to have a post-lunch session as a speaker, but I will try to do my justice. This is an ECG that all of us dread in clinical practice. And there are certain things that I would like you to focus your attention on. You can see this T wave, which is decreasing in amplitude, and then it leads on to a very bizarre rhythm, which we call as torsade de pointe. This actually swinging of the QRS like a seesaw. So you can see the T wave alternates. So the amplitude of the T wave has actually changed, and then it has led on to this arrhythmia, which is very deadly. So why is it so important to measure the QT interval? It is because the rhythm that arises from QT prolongation is fatal. There are a lot of drugs that come into the market, and a lot of them are taken out of the market because they cause QT prolongation. I think all of you would have heard of Caesarpride. It was used in the market very often, and then suddenly withdrawn because of people developing QT prolongation and dying of this ventricular arrhythmia. A lot of quinolones come with a big hype, and then they're taken off the market because of this QT prolongation. And this is a very interesting survey which came out in JAMA, Journal of American Medical Association, and they did a survey among physicians, and they found only 61% actually identified the QT, and 36% actually correctly measured it. So I don't want to take a survey in this audience, but this is what the American physicians did. I think the Indian physicians is a little better than that. Okay, what does the QT interval actually represent? It is both ventricular depolarization and repolarization. So when you measure a QT interval, it is measured from the beginning of the Q to the end of the T wave. And we normally use the limb lead, because that is the best place you can actually see the T wave accurately. So you have here a P, then you have the Q, R, S, T. So, and the U wave. You can see the PR interval is measured from the beginning of the P to the R. QRS duration is beginning of Q to the S. And the QT interval is from the beginning of Q to the end of the T wave. So this is easy in a patient who has got a normal ECG. So this is a patient who's got a normal ECG. You mark out the beginning of the Q and then the end of the T. What is how do you measure if you have a U wave? Like here, you mark out the beginning of the Q, and then you draw a horizontal line from the ST, then draw a tangential line across the T, and then a vertical line where it meets. That is your QT interval when you have a U wave. In some patients, you will never see a upright T wave. You will only see a inverted U wave, inverted T wave, like here. In this, again, you mark out the Q, draw a horizontal line from the ST segment, and then where it meets, that is the end of the QT interval. So these are variations where we have to use tangential lines and horizontal lines to actually measure the actual QT intervals. Now, in patients who have interventricular conduction defects, like patients who have right bundle branch block or left anterior fascicular block or left bundle branch block, this has been published in electrocardiology almost 2 decades ago. They considered that the JT interval is more important and could give a better way of diagnosing QT prolongation. So you can see here the QRS, PQRS, and the JT is from this point, the beginning of the ST, down to the T. So you have a QT interval. So instead of QT interval, taking it from here, you have the interval taken from the J point to the end of the T wave. And this is a calculation that has been brought out called the JT prolongation index, JT index. And this has been found to be robustly show abnormal rhythm, especially if you're considering patients to take QT prolonging drugs. And you have a patient who has got a left bundle branch block, you can use this formula to actually say, okay, this patient cannot be on this particular medication. The other rule of thumb is, which came out in circulation, is in left bundle branch block, you can add 70 milliseconds to the QT interval that you measure. Or in right bundle branch block, you can add 40 milliseconds. So that's another rule of thumb it can use to say whether the QT interval is prolonged in the presence of interventricular conduction defect. Now what happens in atrial fibrillation? We all know that the QT interval actually varies with the heart rate. When the heart rate is slow, the QT is longer, and the heart rate is shorter, the QT is shorter. Heart rate is fast, QT is shorter. So in atrial fibrillation, there is one group of people who think that you have to actually painstakingly take QT interval in 10 RR intervals and then average it. Or you could do 2 simultaneous ones, like shown in this example. The RR is measured here for this interval, and the QT is measured for this interval and for this interval, and it is averaged. The QTC is averaged. So that's another way of doing it in atrial fibrillation. I was just alluding to the correction. We have to correct the QT interval for heart rate because it prolongs during slow heart rate and shortens during fast heart rate. The formula that all of us are very familiar with is QT divided by root of RR. However, this is only robust from 50 to 90 beats per minute. And the other thing that you should keep in mind is this is in seconds, not in milliseconds. So when you measure QT interval, don't write 400 divided by, you don't write 1000 divided by root of 400. It is 1.02 divided by the root of 0.4. So it should be in seconds. So the way to overcome this is the Friedrichs formula, where you have the cube root of the RR, again taken in seconds. But one of the newer ones that has come out is the Framingham's linear equation, because this is a population of patients. What are we interested in? We want to know whether these people are prone for a torsades point. And the QT interval that you're actually measuring, it is going to be a prognostic indicator. You want to know whether these patients are going to develop arrhythmia in the future. And this Framingham linear equation has been derived looking at a cohort of patients and following them up, and they've come up with this equation. Now, the formula for this equation is a little difficult, but if all of you who are very Android friendly and having smartphones, you can actually download it from Medscape. I think some of you may have that, or EP Mobile. So these are the tools that you can use on your phone to measure QT in the outpatient clinic. So Framingham's is probably the most robust among Bassett's and Friedrichs. There's this Hodges formula. There are various other formulas that are used, but in practicality, Bassett's is what we use in normal practice. But remember, if a patient is bradycardic, you can't use it. If the patient is tachycardic, you can't use it. So rather go for Friedrichs or go for Framingham's. What are the causes of QT prolongation? There are cardiac drugs and non-cardiac drugs. I just highlighted some of them which we use commonly. Sotalol now is in the market. We often use it for arrhythmias, especially atrial fibrillations. And the rule of the thumb is you repeat the ECG 72 hours after starting the patient on sotalol. In my own practice, I do not start more than 40 milligrams twice a day because I found that our Indian population do not tolerate very high doses. Maximum I've gone is 80 milligrams twice a day. Whereas when I was in Australia, I used to give 160 milligrams twice a day or even 320 milligrams twice a day. But our Asian, maybe because of genomics, they do not tolerate it. So 40 milligrams twice a day, do the ECG 48 hours after starting sotalol and send it to us. And we do not want the QT to prolong in these patients. And the cutoff is 500 milliseconds. And especially if you give drugs which can prolong QT, like a lot of people give erythromycins, a lot of people use quinolones and terfenadine. I remember taking Trexel for every common cold that I used to come across. So these all can cause QT prolongation. Remember, electrolyte imbalance, toxins, severe bradycardia can cause QT prolongation. And there are structures very far from the heart. It's not uncommon for a neurosurgeon to call you up and say there's QT prolongation because of subarachnoid hemorrhage. So the QT can prolong because of pharmacokinetic interaction, like example is cisapride and ketoconazole. Ketoconazole levels increase by cisapride. Both prolong the QT. Pharmacodynamic is when the like example is quinidine and sotalol. Very rarely, we don't use it nowadays. Both block the outward potassium current. And sometimes you have a mixed interaction where erythromycin and cisapride are given together. Both block outward potassium current and both potentiate each other's levels. So this is a drug interaction. So the guideline for QT measurement, it should be not automated. There is a question that we have Holters. A lot of us use Holters. And we have automated QT intervals coming out from the Holters. And there are studies which have shown that Holter measurements of QT, it is not accurate. And even taking them as cutoff points for diagnosing long QT syndrome is not accepted. So again, you should measure from beginning of QRS to the end of T wave, average 3 to 5 beats, especially if you are in a doubt. Correct it for the heart rate. If you're doing a drug study, do it at the peak plasma concentration, not at the trough level. And U waves are only used if they're very large. Otherwise, you eliminate the U waves. Men QT interval is should be less than 450 milliseconds. Women should be less than 460 milliseconds. And this is related to the estrogen-progesterone interactions. And this is the 3 syndromes that you should be aware of. Long QT1, 2, and 3. Long QT1 is usually physical activities. Long QT2 is auditory stimuli. Long QT3 is sleep. I think my speaker after me is going to speak in depth about long QT syndrome, so I won't delve too much about it. I like pictures, so I'll show you some ECGs of long QTs. This is a long QT1 patient. There are 3 different patterns. This is the infantile pattern. The QT is prolonged and is broad-based. You can see the T wave is broad-based and little peaked. And I have shown only here, notice I have not shown any precordial leads. I have only shown the limb leads. This is not peaked like the infantile pattern, but it's just it is broad-based again. Broad-based T where the QT is prolonged. This is almost looking normal QT, but the T wave looks normal, but the QT is definitely prolonged. And this is a really late normal. The T wave looks normal, but the QT is significantly prolonged. They all belong to long QT1. So what is the Common theme here is a broad-based T wave. It's difficult to remember all the patterns, but if you remember, long QT1 is broad-based T wave. That's one take-home message. Long QT2 is bifid T waves. Okay, and here you can see a T wave which is looking bifid. Don't mistake it for a P wave or a 2:1 heart block. I think all of you should be very careful, especially in a patient who's got recurrent syncope, young boy. Don't put in don't diagnose 2:1 here. It is actually a bifid T wave. You can have a subtle bifid T wave when you can see here, it's on top of the T wave, or it can be on the downslope of the T wave, or it could be just a low amplitude. So all of them are long QT2. Long QT2 is bifid T wave. Long QT3, it is late onset peaked biphasic T waves. You can see the QT is significantly prolonged, almost looks like another complex sitting here, and it is peaked. It could be asymmetrically peaked. This is symmetrically peaked. Here it is asymmetrically peaked. Both of them are long QT3s. So long QT1 is broad-based, long QT2 is bifid, and long QT3 is peak T waves. All of them the QT is prolonged. I think that's an easy way of remembering QT prolongation. Now I've just put in a long QT diagnosis. I was not aware that my speaker was going to, the next speaker is going to speak on this, but very quickly, the ECG findings, clinical history and family history are to be taken in together before you diagnose a case of long QT syndrome. So when you have a patient who comes to your outpatient clinic with syncope, you should always ask, when is he falling unconscious? Is it when he is playing football or exercising, or is just at rest? Because if the patient is having syncopal episodes when they are stressing, it is of more graver importance. He is given a score of 2. Without stress is given a score of 1. And all of us light up when we see a patient who's, especially a child who's got congenital deafness and has recurrent loss of consciousness. Then you always think of long QT syndrome. It's given a point of only 0.5. Then families which have history of sudden death. Families with definite long QT diagnosis or unexplained cardiac death below the age of 30 in the first degree relatives, they are also counted significant. And ECGs, like I said, you measure the QT interval. There's a documented Torsades-Dupont T wave alternance, like the example that I showed you the first slide, where there can be the alternation of the amplitude of the T wave or the phase of the T wave. Notch T waves in 3 leads or low heart rate for age. So if you have a score of 4 or more, it's a definite long QT syndrome. And if you have a score less than 1, it is of low probability. Suppose you have a patient who's suspected long QT syndrome, you can do some challenges. One of the things that is to put them on the stress test and check the QT interval. So during stress test, if there is slight prolongation of QT, it is not of significance. Normally the QT will shorten during exercise. But if it is unequivocally prolonging during exercise, that is a definite indicator that this patient has QT abnormality. Genetic problem is there. An epinephrine challenge, it should be done usually in the ICU setup or in the EP lab after overnight fasting. Keep everything ready for an eventuality. Have the defibs ready. You have to discontinue beta blockers to improve the sensitivity and specificity of the test. And you give an infusion of epinephrine starting at 0.025 micrograms per kg per minute and increase it every 10 minutes for a total infusion of 25 minutes. And you terminate it when there are untoward events, especially when the patient develops non-sustained VT, polymorphic VT, frequent PVCs. When do you say it is, when you monitor, remember to monitor at 50 millimeter speed and you take ECGs and measure it in standard leads, either lead 2 or lead V5. And the positive response is not the corrected QT, it's actually just plain QT, more than 30 milliseconds, when the infusion is less than 0.1. So the diagnostic yield is about 92%, and specificity is about 86%. This is an ECG which I have not seen a patient with short QT, so I've just taken it off the net. You can see the QT interval is really short, and it is less than 340 milliseconds in the limb leads, and this patient is present with sudden loss of consciousness and this family history of sudden death. Remember to exclude metabolic parameters before you come to a conclusion this patient has short QT syndrome. So in conclusion, ladies and gentlemen, we looked at how to measure the QT interval and when there is a U wave, when it's inverted T wave. We've looked at the ECG pattern in long QT1, which is a broad-based T wave, bifid in long QT2, and peaked in long QT3. And stress testing is an important way of screening patients for long QT. So I'll conclude here, and if there are any questions I can ask.
We used to call something called R on T. What is that R on T?
The worry is when there is ventricular depolarization occurring at the same time as ventricular depolarization. So it is always thought to be a precursor for malignant arrhythmia. But I don't know how many of us have actually seen that happening. I have not seen it in my practice. Dr. Narasimhan can comment. R1T was thought to be very, very sinister. Dr. Green, would you like to comment?
Back in the case of prevention of ventricular fibrillation during myocardial infarction, one of the things that we should be concerned about. But it isn't anymore. It's just not something that we worry about.
Thank you.
I now request Dr. Ramesh Pai to felicitate our speaker, Dr. Bobby John. I request Dr. Bobby John to hand over the certificates to the chairperson.